Welcome to The Explainer. Today, we're diving straight into a complex, kind of invisible, but absolutely fascinating world: traumatic brain injury recovery. We're going to explore the cutting-edge clinical strategies doctors are using right now to heal the injured brain, looking at the exact pharmacological tools that can quite literally give patients their lives back.
So here's a question for you. Have you ever wondered how we actually manage the lingering, completely unseen hurdles patients face after a head injury? We hear a lot about the immediate, physical impact of concussions and brain trauma, right? But the neuropsychiatric sequelae, the impaired attention, the sudden aggression, the insomnia, these are the invisible battles that happen long after the initial injury.
Okay, let's dive right into this with a real clinical case. Meet Miss A. She's a 35-year-old woman who got a mild TBI, or MTBI, in a car crash. After the collision, she had post-traumatic amnesia for about 8 hours. But here is the absolutely crucial point. When she got to the emergency department, her CT scan and her cervical spine X-ray were totally normal. There was no visible brain damage whatsoever.
Now, initially, she was just sent home with some ibuprofen and muscle relaxers, expecting to bounce right back. But let's look at the macro reality of her situation. 3 weeks later, her life was basically unraveling. She tried to go back to her normal routine, including her really demanding PhD studies, but she was hit with severe headaches, sensitivity to light, poor sleep, and this extreme difficulty concentrating. And even worse, she started having uncharacteristic, angry outbursts directed at her husband and 3 kids. This right here is the classic presentation of an invisible injury.
And this brilliantly illustrates exactly why ongoing, careful clinical attention is just so absolutely vital. Cognitive complaints, like trouble with attention, concentration, and memory, are incredibly common after a TBI. While most folks with mild TBIs do recover fully, a minority end up with these persistent, overlapping symptoms that drag on way beyond 90 days. It requires really strict medical monitoring because treating the injured brain is a highly delicate process.
Actually, when it comes to treating the injured brain, especially for sleep and cognition, there's a core clinical mantra: start low and go slow. Finding the right medication is kind of like a giant puzzle. It requires immense caution and patience from both the doctor and the patient. You have to constantly weigh the benefits of a drug against its potential for causing even more cognitive impairment.
So how does that philosophy actually translate into restoring focus? Well, there aren't any FDA-approved meds strictly for post-TBI attention issues. None. So clinicians rely on a tiered system of off-label options based on clinical evidence. Tier 1 features your first-line stimulants like methylphenidate and dextroamphetamine. Tier 2 includes medications usually used for other things, like lisodexamfetamine, modafinil for wakefulness, and amantadine. Amantadine actually has the most support right now for improving cognitive impairment after a TBI.
Diving into Tier 1, let's look at methylphenidate, or MPH. This drug is a real game changer for cognitive processing speed and attention. It basically works by blocking the reuptake of extracellular dopamine in the brain. Essentially, it stimulates the cerebral cortex to fight off that severe, heavy mental fatigue you get with TBIs. But remember our mantra: caution is key. Doctors have to monitor blood pressure and do a baseline cardiac evaluation because these stimulants do carry cardiovascular risks. Pivoting back to Miss A for a second, even when she finally started getting 5 to 6 hours of sleep a night, her concentration was still just completely shattered. It was literally impossible for her to do her PhD work. So leaning on that Tier 1 evidence we just talked about, her primary care provider eventually added methylphenidate to her regimen to specifically target that cognitive fog.
But, cognitive fog was only half the battle. We also have to talk about calming the emotional storm. The emotional toll of a TBI is absolutely devastating. Remember, Miss A was dealing with these really uncharacteristic, frightening, angry outbursts at her family. Patients can develop a seriously short fuse, getting easily agitated or even verbally aggressive months or sometimes years after the original injury.
So, how exactly do doctors treat this kind of impulsivity? Well, it depends on the timeline. In the acute phase, like right after the injury, actually, scratch that. Specifically while still in the hospital, doctors might use short-term antipsychotics or benzodiazepines. But there's a huge catch. Acute meds like benzos can cause sedation and unwanted cognitive impairment. In the chronic phase, which is where Miss A was, doctors shift to medications like beta blockers, antidepressants, or amantadine to manage that long-term irritability without sedating the patient.
For Miss A, her doctor made a really targeted choice, a low dose of the beta blocker propranolol, and this hit two birds with one stone. Propranolol helped calm her irritability and mood, while also working as a prophylactic to cut down the frequency of her severe headaches, and it did all of this while intentionally avoiding any medications that would make her groggy or sedated.
Now, speaking of avoiding sedation, we absolutely have to talk about sleep. Roughly half, 50% of all patients with a TBI develop some kind of sleep disturbance, and nearly half are officially diagnosed with a sleep disorder. Impaired sleep was one of Miss A's biggest complaints. Without sleep, the brain simply cannot heal, and that exacerbates every single other symptom, from the headaches to the irritability. When we look at the pharmacological options for sleep, the data points us in a couple of directions. A couple of small randomized controlled trials showed that melatonin significantly improves subjective sleep quality and sleep efficiency, and it does it without causing serious adverse events. On the other side, drugs like modafinil can improve excessive daytime sleepiness, but they don't actually fix post-traumatic fatigue. For Miss A, it was a no-brainer. She was started on melatonin to tackle her insomnia safely.
I really want to pause on this number for a second. 70%. For patients dealing with both PTSD and a TBI, roughly 70% suffer from nightmares. This isn't just about waking up groggy. Nightmares in this population are tragically linked to a much higher risk of suicide, especially in service members. The frequency and intensity of these nightmares, that is a massive clinical red flag.
Because the stakes there are just so incredibly high, treatment often has to go way beyond pills. Enter cognitive behavioral therapy for insomnia, or CBTI. This is a non-pharmacologic strategy that yields clinically significant improvements over, say, 6 to 8 weeks. It involves really strict stimulus control, like only using the bed for sleep, along with sleep restriction and rigorous sleep hygiene. It basically retrains the brain to associate the bedroom with peaceful rest instead of tossing and turning.
And for those really severe nightmares we just talked about, there's this absolutely fascinating intervention called image rehearsal therapy, or IRT. Patients literally rewrite their own nightmares. It's wild. Step 1, you close your eyes and picture the nightmare. Step 2, you develop a preferred, acceptable new storyline to replace it. And Step 3, you rehearse that new dream for 15 to 20 minutes every single night. It empowers patients to take their sleep back without needing additional potentially sedating meds.
Taking all of these pieces together brings us to the ultimate goal, right? The road to recovery. How did this giant clinical puzzle actually give Miss A her life back? Well, it required taking a step back and treating the whole patient, not just playing whack-a-mole with isolated symptoms. Her doctor didn't just throw a bunch of pills at her. They used a truly holistic, multimodal approach. Physical rehabilitation was just as important as the pharmacology. She went to physical therapy for vestibular rehab to cure her vertigo. She used acupuncture for her neck pain. She took propranolol for the headaches and irritability, melatonin to get her sleep back on track, and MPH to finally regain her focus for her PhD. And you know what? The results completely speak for themselves. 1 year later, Miss A was virtually transformed. Thanks to this careful, structured plan, she was successfully weaned off both the methylphenidate and the propranolol. She went back to full function at work, at home, and in her studies. She only needed over-the-counter pain relievers for the occasional headache and was totally satisfied that she had fully recovered from her TBI. It's honestly such an incredible success story of human resilience. But it leaves us with a pretty provocative thought. With so many clinical, pharmacological, and behavioral tools available right now to heal the brain, how do we make absolutely sure that no one suffers the invisible sequelae of a TBI in silence? Comprehensive, patient-focused care is out there for sure, but recognizing these hidden symptoms is the absolutely crucial first step. I really hope this explainer gave you a deeper appreciation for just how beautifully the brain can be guided back to health.